Untold Physio Stories is part of the all-new PT Podcast Network. Find a new favorite podcast by an amazing PT content creator at ptpodcastnetwork.com. The future of medical documentation is here, and it's revolutionizing the way we record patient visits. Introducing Comprehend PT, the groundbreaking HIPAA-compliant AI scribe designed specifically for physical therapists. Imagine a world where the dialogue between PTs and patients is interpreted by AI into precise, real-time medical notes without lifting a pen or tapping a keyboard. Comprehend PT does just that, allowing healthcare professionals to stay engaged with patients rather than buried in documentation. Boost your efficiency, reduce claim denials, and liberate yourself from the burdens of manual note-taking with Comprehend PT. Join the revolution now at comprehendpt.com. Untold Physio Stories listeners get 50% off their first month with code MMT50, and there's a free trial available. Sign up now. I use it every day in the clinic for virtual and live visits. I just speak to the patient, and at the end, hit Comprehend, and a SOAP note's generated. I love it, and you will too. Welcome to Untold Physio Stories podcast, your perfect commute resource with physio failures, successes, interesting cases, and more from the physio and rehab world, with your hosts, Drs. Andrew Rothschild and Erson Religioso. Welcome back to Untold Physio Stories podcast. I'm one of your hosts, Dr. E, with Modern Manual Therapy, Edge Mobility System, and my new online private network, The Eclectic Approach. Check that out, modmt.com/members. Today I have a very special guest, someone I have crossed paths with many times on social media. It was kind of amazing to me that we have never met, I guess even virtually face-to-face, which we're doing right now. It's Dr. Mark Kagela. Kargela?
Close.
Kargela. Oh, gosh. Well,
all good.
All right. Yeah. Well, I guess try pronouncing my last name. See what you got.
Religioso.
Oh, not bad. Not bad. Yes. It's Spanish, not Italian.
Oh,
Religioso. Yeah.
Religioso.
No problem. So you can see why I go by Dr. E. Yeah.
Yes, sir.
Anyway, he's from Modern Pain Care, and I think we've had a similar journey, and he's definitely got a story for us. So give us a little intro, and then give us your story, Mark.
Well, yeah, thanks for inviting me. It's good to be on. And like you said, it's good to finally meet you, even virtually. Hopefully we'll cross paths in person one day. But yeah, I've drawn to your content as well, just because it is a similar message, similar journey that we've had in the profession. I've been a physical therapist for 20 years now. I graduated back in 2003 from Grand Valley State in Michigan. I came out of school kind of really, very motivated to become, skilled in manual therapy. And not a bad motivation. It just has morphed over the years as far as what I've kind of prioritized in practice, and similar to yourself. In my journey, I've been I've practiced in hospital-based settings. I've practiced in outpatient kind of practices that were kind of more private practice. I had a failed attempt at private practice here in Phoenix. That's actually when I moved down to Phoenix probably about 6-7 years ago. Not having any idea of the business side of physical therapy, just thought my letters were going to magically make people appear at my front door, and I was going to have customers. But so it's been a journey of really hammering away at manual therapy training. Had some existential crises along the way where, there've been a few times where I was like, man, I don't know if physical therapy is the thing for me. I just can't, I never felt like I was arriving to where I was feeling comfortable, and I could, in early stages, it was like, I'm just going to fix people, and they're going to be, I'm going to identify it, fix it, find it, fix it, and kind of be that hero of the day to save people. But it's changed a bit. I mean, I think I've kind of redefined my role as being that guy by the side. Our friend Rod Henderson that we like at Modern Pain Care talks about being more of an Alfred versus a Batman in the situation. So that's been kind of my rehab approach. That's kind of morphed over the years. And practicing right now. I'm a clinical assistant professor at Midwestern University, which is primarily seeing patients. So I see patients pretty much 32 hours a week, and then we get the opportunity and privileged to have some students come in our curriculum to mentor them. And that's my passion, is to kind of translate research and curricular stuff to real humans in front of you. Because as you know, that clinical reasoning component, we get taught a very black and white version, because that's, we've got to pass board exams and we have to do all the things as a physio going through the training. But that people don't always fit those nice black and white PowerPoint definitions of conditions and how they're going to present to you. So my passion is helping translate, that type of the books to the real people in front of us, and how do we kind of make, ideal interactions with people to where we're moving them in a good direction.
Yeah. So tell me about then one of these existential crises. Like what was a big one, or what made you think manual therapy maybe isn't the end all be all?
Oh, well, I got into fellowship. Gosh, it's been about 11 years since I graduated fellowship. I did evidence emotions fellowship. I had been communicating with you along the way when I was doing that. I was going to see if I could come out to, I think you were in New York at the time, to see if I could do some mentoring hours under you, as you would be my mentor. Didn't work out, just, logistics. I couldn't make it work. But I had a point before I got into that fellowship where I just was struggling with like patients, patients that didn't fit, and, where I was trained. I went through St. Augustine's program and it's very segmentally specific. And there's some things.
Do you know what this is?
I do. What is? Remind me. It's bringing up some memories.
Again, this is not normally a video podcast, although maybe I should start posting these to YouTube. But what I'm doing is I'm holding like a sideways peace sign in front of my palm. So this is what University of St. Augustine, some instructors used to call the sign of the manual therapist, because this is how they're taught to do passive intervertebral motion testing. So you put like your two, like the peace sign pads on spinous processes, and then you push with your other hand. So that's like if you flash this to other physical therapists, and then you're supposed to get the head nod, like, oh, I know what you're all about.
Yeah, exactly. It's like the secret handshake of the old
right.
boys.
Yeah, it's the secret handshake of the manual therapist.
Yeah. So, I'd gone through and got certified through that. I remember sitting in front of Stanley Paris, like sweating and nervous as all get out, because I'm sitting in this guy's office. He's obviously done some amazing things for our profession. I remember I had to like recite the exact biomechanics from CO to C3 in rotation of the spine. And I'm like, my voice is shaking. I got through it and passed. And I remember our table broke and he got mad, not at me, thankfully, but he was all, and so it was a stressful experience. Got through that and then took that. And then when I got done, I was working in a clinic where there was a lot of MDT clinicians, and we had a relationship. We were kind of an outpatient wing of a hospital-based system. So we had a neurosurgeon group that would only send patients to McKenzie therapists. They had to be credentialed. That was just their way of having a quality check, I guess, on physical. And it really rubbed me the wrong way. I initially started out like I disliked McKenzie strictly for that reason. I felt like disrespected, like, why can't I see these patients, all these things. But then I worked with patients who did it, and we had this pathway, like if you weren't getting somebody improved within 6-8 visits, you were struggling, you would refer it. And one of my mentors was a McKenzie therapist, Jim Hartline, great guy. I don't even know if Jim's practicing anymore. He's doing some great things administratively. But anyway, I'd remember like I'd see patients make like a massive 180 with like one session of like repeated motions work. And as you know, it's kind of a very big difference than the very segmentally specific. It just throws that out. They don't, what's happened at the facility? I don't know what's happening. Who knows? Where
right.
It's
yeah.
all,
there couldn't be two more different approaches, right? Especially because like going to University of St. Augustine, they pretty much bash that. Like they take every single issue with McKenzie method and just bash it and bash it and bash it, and you just come out of it thinking like, oh yeah, it's garbage, right?
Yeah, and I definitely fell into the whole tribal thinking, group think of like, yeah, this McKenzie stuff's garbage and blah blah blah. So I had that, and then eventually my ego had to be set aside, because there's patients were going to see folks who were using MDT and making significant changes. No, I'm not going to say it was like some sort of like everybody got better. There are still patients that are with complex pain conditions where McKenzie nor Stanley Paris's work and things were going to be the solution per se. It was a lot more complex than that, but it really drove me to kind of get into MDT, and it's pretty much the primary way I kind of interact with the spine. I definitely interact, and I'm eclectic like yourself, where I will definitely maybe break the force progression rules and different things, more quickly and start. And, as you kind of get in the clinic, you kind of get, especially if you're using a good reasoning process, you see some patterns, form of like, hey, when I see this type of presentation and jump in a little bit more quickly to do some more passive based, loading versus active, patient generated stuff, I might be able to make some outcomes a little bit more quickly. So, and I've been fortunate in EIM's program, but even, let me actually back up. I got to a point even where the McKenzie stuff, there was just still a group of people where, whether I was using more traditional St. Augustine based stuff or using McKenzie based stuff, And I had been sprinkling in, I had gotten into some MET. We were close to Michigan State, which is one of the hubs of the osteopathic training. So I had my dance with OMM based
With
stuff.
Greenman.
Yeah, exactly.
The Swedish chef, I call him.
Yeah. So that was, obviously a very, very taxing. I think, again, you can name SI dysfunctions in 18 different ways, depending on what you're talking about. So that was another thing. Like that system immediately just was too much of a brain. I mean, there's definitely some things I took out of it. And as with anything, you can probably grab some stuff that, you bring with you, find what actually makes change with patients versus what's theorized to make change with patients. There tends to be a lot of fluff out there and a lot of that stuff. But I hit a point where even with all that stuff, I was feeling like there are still a group of people that it ain't happening with. I was not helping. I was not finding it and fixing it. It was, and these often, now looking back, were just these patients that had complex pain conditions, chronic pain, persistent pain that was much more than just a tissue issue. Obviously, I was searching for answers mainly through tissues and thinking that, if I can't symptom modify it through a McKenzie approach, there's got to be some specific dysfunction that I can get in with my hands. And then was finding like, yeah, okay, it ain't happening. And I had a point where I was like, okay, I was considering, I was in contact with Michigan State, like, okay, I'm just going to go to the DO program and I'm going to start an application. So I was like getting ready to take an MCAT and do all the things to get into med school there. And I thank God I don't, nothing against, and I think a lot of my DO colleagues were actually going to interview Oliver Thompson, who wrote the, issues with osteopathy article on our podcast. But there's some issues as far as very dogmatic theory-driven stuff of positional diagnoses and things. We know research hasn't really supported it yet. It's kind of like again, we all get in the old boys club of OMM where, we're so confirmationally blinded to see that there is maybe some questioning of our theories anyway. So I was like ready to quit, and thankfully I didn't do it. I had some colleagues I leaned on and talked to when I was going through that, and they suggested trying for Evidence in Motions Fellowship, because then research was going to be the answer. I was going to have CPRs and I was going to be able to just use research to kind of guide myself. And that was going to be my fix, my solution. Like I was just going to practice. And again, there's some good things about that. Of course, we don't want to just practice where there's no boundaries and we're just doing whatever the heck we want. So I think, my research definitely gives us the kind of bumpers or, boundaries of where we need to be within a low back case and different things. But within that, obviously, we do a lot of mentoring hours with clinicians. I learned some amazing things there. I think the biggest thing is they really got into Maitland reasoning stuff, which is, test, treat, retest, and, really staging a patient using the SINS model and things, which was helpful because it helped me kind of adjust myself to patients and not just everybody. This is Mark Kargela's evaluation that I fit everybody to. It's a very, good way to just help yourself fit yourself and stage a patient and make sure you're applying your testing and your treatments very much more tailored to that patient's unique presentation that day. But still, in my mentored hours, I was fortunate to work with some great manual therapists, and I still saw the same patients. And it was at that same time I was reading Lewis Gifford's books, his series of aches and pains books. And I remember kind of feeling very similar to some of the stories he talks about in that book, where he was practicing with Jeff Maitland and seeing the same patients, because again, as you get well-known like Jeff Maitland's and even some of the therapists I was mentor on, you get all of the tough cases. And often reason that some of the clinicians who refer to them aren't getting anywhere with those patients, there's a good portion of those patients, probably because it's a complex pain condition that's not going to be solved through a very focused tissue approach. So seeing that, I was like, oh man, I thought this was going to be the solution. And, CPRs weren't figuring it out, and then the research obviously is questioning their utility and they, serve as maybe a blip of information and not much more at this point. But so again, I was ready to just hang it up. But at that time too, Steve George and Joe Bialowski, we were fortunate to have them come in, and they taught a Why Manual Therapy Works course. So that was like really showing that, okay, manual therapy works much more than just at the tissue level. Kind of opened up considerations into the spinal cord and brain, and then the whole interaction and contextual components. And they've obviously done some great stuff with mechanistic research around manual therapy and kind of really showing us that, man, the bigger part of this is more spinal cord brain related mechanisms of effect. So that kind of took a weight off my shoulder. Okay, that makes sense why if I'm just paralysis by analysis through the tissues, like it isn't going to make sense, because a lot of what's going on and driving these things. Now I can put an input into those tissues peripherally, but the change is probably not happening. The changes might materialize themselves peripherally, but where the real change is probably happening, spinal cord and brain levels. And So that was like an aha moment. And then just was fortunate to go into a pain science course at that time. And that was kind of like, okay, those patients now make sense. It made sense. My mentors that I was with, great. I'd send family members to them for if it was like a more focused tissue-based issue, but I wouldn't send my complex pain patients to them. And I think, in their defense, they probably would say the same thing. I'm more going to be better for, a more specific spinal condition versus somebody who's had, 15 years of persistent low back pain with multiple failed surgeries and all these different things that obviously muddy the waters of going to find some specific thing in the spine that you're going to solve things with. But so yeah, that was really kind of my like, okay, I'm gonna ride this thing out, and that's what really drove me to start Modern Pain Care, because I felt like there was a gap out there in education of teaching clinicians. I wish I would have had why manual works and pain science right out of school, because it would have saved me a heck of a lot of frustration and stress of feeling like I was a failure. The imposter syndrome obviously weighs heavy when you're feeling like, man, stepping into treatment rooms and I have no idea what's going on and what I'm doing just isn't cutting it. And now I feel much more confident. Now I don't feel that pressure. It's more of a partnership of finding ways with people. I definitely interact and put my hands in there from time to time, but it's definitely more of a guide by the side type of approach.
I like that. Be Alfred instead of Batman. That's pretty good. Yeah, wow. I mean, geez, if we had like the same origin story, but you were like 5 years behind me, pretty much it. Although, see, the problem is I never had imposter syndrome. I only thought I always thought I knew what I was doing. And the more courses I took, I just thought I knew more. And I was always looking, of course, for soft tissue work is the next thing, neurodynamics is the next thing. Oh, when I took Butler's first pain science course in the US, I'm like, this is definitely the next thing. I'll be able to help everyone now. And like every single thing I've ever learned, I was confident that I'd be able to help everyone now. And then whenever I came across Bielowski's stuff, that actually didn't like, of course, it changed everything I thought. And ever since then, I always just say that I wish I had like if I could bottle up some of the overconfidence that I had, because now all I have is questions.
Mm-hmm.
Even though I'm like confident I can help the majority of people, anytime it doesn't respond like I think it should, and it's not some kind of clear differential diagnosis that should be ruled out, I'm just thinking like, what am I missing something? Because I just don't have that confidence. I question now more than I used to, which is probably healthy. But I just wish I had a little bit more of that confidence that I had early on in my career. Mark and I could have went on forever because we had so much in common. So I decided to split this 30-minute podcast into two 15-minute more digestible episodes. Check back next week for part 2 of becoming Alfred and not the hero. In the meantime, make sure to rate Untold Physio Stories 5 stars wherever you listen to podcasts. Hit that subscribe button, and please, definitely, again, rate us 5 stars, especially on Apple and Spotify. And as always, you guys have a great day.